From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA podcast. I'm Dr. Kirsten Bibbins-Domingo, and I'm the editor-in-chief of JAMA and the JAMA Network. I'm joined today by Dr. John Ruiz, professor of clinical psychology in the Department of Psychology at the University of Arizona, where he is also director of diversity, equity, and inclusivity. Dr. Ruiz is also a member of the U.S. Preventive Services Task Force, and he's joining us here today to discuss two new related recommendation statements from the task force: screening and preventive interventions for oral health in children and adolescents ages 5 to 17, and screening and preventive interventions for oral health in adults. JAMA has published these recommendation statements and the evidence reports on which the recommendations are based. Dr. Ruiz, thank you for joining me here today.
Kirsten, thank you so much for having me. I'm thrilled to be here with you.
Wonderful. So, John, if that's going to work for you, and please call me Kirsten, I would like to start, as I usually do, by asking you to give me just the general take-home message from these recommendation statements. You have two, but they move both in the same direction. So what is the take-home message at the high level?
Thank you so much for asking. So healthy teeth and gums are an important part of overall health. It's essential that we have important guidelines and recommendations to guide screening and interventions in the primary care setting to help our populations have optimal oral health. So the task force reviewed the available evidence in this domain. It did it in two parts: for the ages of 5 to 17, and then for the populations of 18 and older. And in both cases, unfortunately, the available evidence was insufficient to conclude the relative harms and benefits of those interventions and screenings on outcomes. So for this reason, both recommendations for the populations of 5 to 17 and for 18 and older received an I statement at this point.
We'll talk about what an I recommendation statement means. And the task force usually issues an I statement when it wants to say, this is an area we need more research. But I want to start by trying to give our listeners a sense for what types of interventions or screening we're talking about. Because we're not talking about should people go to the dentist. We're talking about in the primary care setting, what types of things should we do in the primary care setting to address oral health? Am I stating that correctly?
Correct. What we're talking about here is when a person goes to see their primary care physician, what can be done efficiently in that setting. The primary care setting is important, and it's a wonderful catchment for a broad swath of the population. During those visits, we can efficiently assess a number of health conditions, and the task force looked at the question about whether oral health was one of those. Simply stated, the physician may ask the patient to open their mouth, look in, and the question is, could they assess accurately whether there were issues such as cavities, which we're all concerned about or should be, and in older populations, whether there was any evidence of gum disease. In both cases, the task force then also looked at the related question of interventions. Could anything be done in those primary care settings to mitigate any issues observed?
So tell me a little bit more about the scope of the problem and really what the consequences are of not doing anything about oral health. So who has problems with poor oral health? How widespread is it? And what are the consequences of doing nothing about it?
So oral health is something that we all need to be concerned about. Every person, as they age, as they go through daily life, can encounter challenges that may affect their oral health. We're all encouraged from a young age to brush and hopefully floss, and many of us have had that uncomfortable discussion with our dentist about, well, are you flossing all the time, kinds of issues. The question here is whether for people without signs or symptoms, if there is a way to efficiently observe and detect whether oral issues are happening. Oral health, importantly, doesn't affect the population equally. Certain populations are at greater risk. Those include people who live in lower-resourced communities or have less opportunity to engage in proper oral hygiene and preventative efforts. Many racial ethnic groups also are at higher risk. And certain populations, including those living in rural areas or in specific regional parts and communities throughout our country, are also at higher risk.
I imagine that given that it's common in lower resource communities, and you've described several ways in which certain demographic groups are more affected, that one of the issues of lower resource might be access to a dentist or might be efficiency around if you're going to primary care anyway to be able to assess oral health. And that adds an importance to looking at this as a potential way to intervene on oral health.
That's a great point. And I think what you're speaking to there is differences in access, differences in health equity throughout our populations. The topic of dental care, I think most people naturally think of dentists, but not everybody has access to dentists nor the same quality of dentistry. Given that, the task force focused on primary care as a more accessible type of care and whether some of these frontline preventive types of screenings and interventions could be engaged efficiently and accurately in that setting.
And what kind of consequences of poor oral health was the task force interested in the evidence?
Oral health can affect everything from diet and nutrition to employment opportunities. We think about the importance of a healthy mouth, teeth, a nice smile. It has implications for everything from what we eat and the comfort that we experience in that, how we speak, how we socially engage with other people, our own self-esteem, occupational opportunities, and overall quality of life.
So it might seem to some listeners like this is an issue of access. We've already talked about there's some efficiency maybe in the primary care setting. Not everyone has access to a dentist, but I'm sure for some who have not necessarily thought a lot about this issue, there is a question really, why are we focused in the primary care setting? It is notable that the task force does have a recommendation for oral care in the primary care setting. So talk to me a little bit about that recommendation.
I think you may be referring to the under age 5.
Exactly.
So the under age 5 recommendation statement, in that context, there is sufficient evidence to evaluate the effectiveness of interventions. And essentially what primary care physicians for children under age 5 are looking for is that first breakthrough tooth, and then upon seeing that, treating it, giving it a fluoride varnish, as well as the other teeth as they come in, as a protective preventative intervention. In addition, beginning at age 6 months, populations where there is a fluoride deficiency in water sources, they are provided with recommendations for fluoride supplements to promote healthy tooth development.
So what I hear is you saying that there is in fact evidence that in primary care settings, attending to oral care in those settings, screening and intervention for those under age 5 actually is associated with benefits that outweigh any sort of risks of doing so, and that we have evidence to assess that for those under 5. The task force looked to carry that idea forward to those older than 5, the adolescents, the child and adolescents older than 5, and then adults. But in there, we don't have enough studies.
Yes, the key there is the word evidence. The task force's recommendations are always based on an evaluation of the harms and benefits of the available evidence. In the under 5 group, the evidence was sufficiently present to allow for that cost balance determination to be made. But the new recommendations, unfortunately, there was insufficient evidence to make that final determination. And that's now what the USPSTF is calling for.
So again, an I recommendation, although it does leave clinicians sometimes wondering, well, what are we supposed to do? And I'm going to ask you that question in a second. First, I want to know, for those of us who do research, what should we be doing? What type of evidence does the task force need?
Clinicians and research go hand in hand, and the task force really seeks to facilitate that so that we can all engage in the outcome of optimal health for our populations. The research guidelines are a critical part of I statements, as well as any of the recommendations coming out of USPSTF. The task force evaluates the evidence and highlights research gaps. Those research gaps are then articulated or described in the final recommendation statement, and they essentially paint the road towards which the task force needs evidence to make its determination. In this case, the task force needs additional evidence to evaluate screenings and interventions in primary care settings with a diverse population that represents our various communities. If that evidence can become available by the time that the task force revisits this topic in 5 or so years, then we'll have a much better chance of being able to make that determination of harms and benefits.
So I think the key here is that you need evidence in the primary care setting, not showing that dentists taking care of oral health in patients improves outcomes, but really in the primary care settings.
Right. We know that certain settings are particularly good at doing a variety of screenings and interventions. The question here is whether oral health screenings and interventions can be done efficaciously in that primary care setting.
Mm-hmm. So while we're waiting for the research to develop, what words of wisdom does the task force have for clinicians? I'm a general internist. I have colleagues who take care of patients in an adolescent clinic. What other guidelines can we point to, or what other recommendations does the task force have?
So there's really sort of 3 things I would outline. First, for your populations under age 5, we continue to go by the existing guidelines, which do recommend intervention in the primary care setting. For those 5 and up, we have a couple of options. If the person before you is symptomatic, is showing any signs or symptoms, then we of course take that and make appropriate referrals and intercede in ways that are appropriate. The big question here though is, what about those who are asymptomatic, who don't show any signs or symptoms, and they're in that over 5 age range? For those, we rely on our clinicians to use their best judgment going forward, as they would for most conditions. What do they feel is going to be most helpful for the individual sitting in front of them? Do ask that they consider that there's an important variation in risk, as we talked about earlier, that those who are lower resourced, underrepresented racial ethnic groups, and those living in certain rural settings may be at higher risk, and to incorporate that into their thinking and recommendations for that particular patient.
Wonderful, wonderful. So I'd love you to take us home and give us the final summary. What is the task force saying as they looked at oral health screening and interventions in these populations?
So we have 3 take-home messages, really. The first is for the populations under age 5 to continue moving forward with the guidelines regarding interventions. For those who are age 5 and up, but perhaps symptomatic, then clinicians can use clinical judgment in making appropriate referrals and taking mitigative actions. And then finally, for those who are over age 5 but without signs or symptoms, again, using best judgment as we wait for researchers to catch up and provide us with the evidence we need to make those final determinations.
Thank you so much, John. I've really enjoyed this conversation. I hope you'll come back again for our next set of recommendations from the task force. I've been speaking with Dr. Ruiz, a clinical psychologist and the member of the U.S. Preventive Services Task Force, about the new task force recommendations on screening and preventive interventions for oral health in children and adolescents ages 5 to 17 years, and the accompanying recommendation, screening and prevention interventions for oral health in adults. This episode was produced by Shelley Steffens at the JAMA Network. And to follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.